Good morning, everyone, and welcome to what's going to be, I think, a very exciting symposium. I'm Greg Sawicki from Boston Children's Hospital.
And I'm Cindy Brown from Indianapolis, Indiana University.
And we are thrilled to have four incredible talks on some ongoing, exciting research in what is the new era of cystic fibrosis care. And we titled this symposium, Living in the Post-ETI Era. Questions and answers are through the app, so I think hopefully people have been familiar with that for now from yesterday, and we'll try to get questions, as many as we can. We'll take questions after each of the speakers, but then also if there's time at the end, we could have some questions sort of more broadly as well. But our plan is to have each of the speakers speak and then have some time for questions about their individual work. And Dr. Brown and I just wanted to start with a message to the CF community before we start the symposium. But we wanted to make sure that in this era of divisiveness in our country that we think about this at the level of meeting planning. So for the safety of our presenters and attendees, we both urge the CF Foundation to commit to ensuring that future meetings are held in locations where elected officials and leaders understand the importance of gender-affirming care, reproductive freedom, and the sanctity of the physician-patient relationship. So it goes without saying that modulators have changed the face of CF care, and this is data from the CF patient registry up through 2021. Showing the prescription of different modulator therapies to people with CF in the United States. And what you clearly see is that with the introduction of tricaftor or triple combination therapy in 2019, we have an explosion in the number of people that are using these therapies. It's also linked with, and one part of, but not the only reason for improvements in outcomes, but we are now in an era where people with CF are living longer with better survival, but also with better outcomes at multiple different ages, whether you look at pediatric populations, adolescent populations, or adult populations. And so understanding the impact of these therapies is critically important.
So over the next 2 hours, we're going to hear from our colleagues from Promise, Simplify, CF Storm, and Hero 2, all of whom are looking at a variety of outcomes. Can we simplify treatment? What are the treatment burdens? What are the other outcomes that we are seeing in the post-ETI era? But really, this is the tip of the iceberg. There's going to be so much that we learn over the next 3 to 5 years from a variety of studies, both in the United States and in Europe. It includes things like Mayflowers, which is looking at health outcomes in pregnancy and the infants, looking at the value CF, looking at trade-offs. What would people be willing to lose in their lung function if they can remain off therapies? Looking at their liver disease, looking at the infants in Begin. So with that, I would like to begin our session, and I would like to invite Dr. Nichols or Dr. Solomon to present.
Better if Greg messes this up first before I do. So, perfect. Okay, great. Oh, perfect. I'll try to use all this technology. So I want to say thank you very much to Greg and Cindy for the opportunity to speak, and thank you guys for coming and making yourself present before the other more interesting talks are going to be delivered, especially Dave's results of the Simplify study. So I appreciate you guys prioritizing to come early. So I'm Marty Solomon, and again, I really appreciate the opportunity to present the results on behalf of a large, I would say a small to large village of people overseeing the Promise study. I'm gonna see if I can make these slides work. I think I've finally gotten the clicking right with this system. So these are my disclosures. I'm gonna start with this, what may be considered a busy slide, but the concept of this slide is that there's been a lot of study looking at the post effects of highly effective modulators over the course of the last 10 years. A lot of single center and multi-center studies, which all leave us with lots of questions. So the point of this study is to say that we envision a study like the PROMISE study, which I'll introduce to you guys in a moment, really to be hopefully continuing to answer some of these unanswered questions about various effects of modulators throughout the systemic disease with CF. So the PROMISE study is a prospective study that evaluates the biological and clinical effects in a real-world experience of significantly corrected CFTR function with ETI or elexacaftor, tezacaftor, ivacaftor. And there's really sort of three themes that I've envisioned with the PROMISE study. One is understanding the biological mechanism of the primary pulmonary effects, and very importantly, expanding our knowledge of both outcomes and extrapulmonary clinical outcomes and the mechanism of non-pulmonary disease with ETI, and then the durability of these clinical responses in a real-world setting, especially with our extension study, which I'll be talking about in a little bit. And really want to hope to confirm findings we found with ivacaftor in the GOLD and GOLD-E2 studies, which were very similarly designed and concluded a couple of years ago. So the study design for this, for those that are less familiar, is this was a real-world study that was observational, open label, incorporating a pre-drug baseline, and then patients started their ETI. This goes back to 2019, before the pandemic and the days of old. And then patients had several early-term biological and clinical impact visits, and then several visits at later on, going initially to a 30-month visit being our initial conclusion. As I'll talk about later, we do have an extension study that I'll give you the rationale and the future for in that at the end of the talk, but the initial study was comprised of about a 24 to 30-month visit. There obviously were some interruptions with the COVID pandemic, but didn't really affect our outcomes. We've been actually very successful in this program with overcoming those issues. This is the list of PIs, and so what you can see is this is literally a village. There are so many sub-studies that happen with PROMISE, and that means that there is a ton of data. So I'm speaking on behalf of many of the PIs now. We'll give you guys a very high-level overview of some of the sub-studies which we're proud to be presenting, and also try to direct you to talks which will drill down much further into those outcomes and that data rather than stealing that thunder. So thank you to all the PIs for offering to present some high-level data, and also for your hard work, and as long as the study coordinators. So the study really is one of those that answers a lot of questions besides pulmonary effects, and finally gets kind of below the diaphragm, out of the thorax, and beyond to the systemic effects of this illness as well. The PROMISE older cohort, which was the initial part of the study, so 12 plus, which started enrolling in the end of 2019, early 2020, has completed enrollment through visit 6. As you can see, despite some drop-offs in our kind of visit 3 with the COVID pandemic, we continue to enroll well in the overall cohort, as well as many of the sub-studies which have enrolled quite well. So I think it's a testament to the CF clinical research engine that can keep that going despite a pandemic. And we've enrolled across the genotypes, you can see from the table on the bottom right-hand side of the slide. The overall PROMISE 12 plus results, which were originally published in a publication that came out this year and led by Dave Nichols, showed confirmation of many of the early term effects in a real-world setting that we saw in the pivotal studies of ETI, including improvements of lung function, reduction of sweat chloride, improvements of symptoms, and BMI. And there was a modest correlation, interestingly, which was a mechanistic finding from this, a modest correlation between the reduction in sweat chloride and improvements of lung function, which has not heretofore been shown in a larger study. In addition, there have been some mechanistic insights about interactions between gender, race, and age and whatnot. And we found that female patients with CF have a larger sweat chloride improvement, which is not unexpected. The symptom improvement on the whole was improved with larger among older and female patients. However, there was no identified interactions between lung function, change in age, sex, ethnicity, or race on a kind of multivariable regression analysis. And so a stratification also by baseline lung function shows there's significant improvements in each baseline lung function group. So we think there's a generalizability of the lung function improvement. So those are some new mechanistic insights. In addition, I'm proud to say that we've completed the initial analysis of the pediatric sub-study, the 6 to 11-year-old patients. This was led by Margaret Rosenfeld, Jess Pittman, and Felix Ratchet, and will be presented in a workshop by Felix, workshop 21.1. The kind of top-line data is there was confirmation of some of those key clinical outcomes in the lung function and improvement in symptoms. And interestingly, as you can see by the right-handed graph, an improvement towards negative cultures in this population. So So that's an interesting finding and something we hope to continue to show as this study matures and the overall cohort matures. So that's looking at the right-handed graph showing more purple equals more negative cultures on a qualitative basis. So I want to share with you guys some of the pulmonary mechanistic insights. This is work from sub-studies conducted at UAB and other sites, including UNC. And so what we found from in vitro cultures using human nasal epithelial cells is that the CFTR activation response to elexacaftor, to ETI, in fact activates CFTR as we expect, and this results in increased hydration of the mucus layer as shown by the change in ASL, that middle graph, whereby post-ETI patients had improvements of hydration status, which we think is mechanistic for improvements in overall pulmonary endpoints. In addition, in these studies, the change of airway surface liquid appears to correlate tightly with the level of rescue of CFTR, which is an interesting mechanistic insight we hope to explore in the future. In addition, we'll be doing correlations to individual clinical outcomes in the study to confirm the utility of this as a biomarker for modulator responsiveness, and as well as a large number of collaborations to answer these type of questions. In addition, our group has been able to look at the role of in vivo micro-OCT. I'm not going to go through that in significant detail for this study, but please look at this poster in abstract number 155. So we did a pre-post study looking at a baseline in vivo imaging in the nose prior to study, and then following approximately the visit 2, which was delayed because of COVID, so it being about 50 days post-enrollment in the study. And we found in this paired OCT analysis there was a significant improvement in the microscopic mucociliary transport rate, but a discernible mechanism from increasing cilia beat frequency or airway hydration was not observed with this. And there were trends towards positive correlations between sweat chloride reduction, post-ETI, and mucociliary transport rate improvement. And so we will be extending this study out to a visit 3, which is part of our extension plans for the study to answer longer-term questions about these in vivo biomarkers. In addition to this study, we found that the epithelial properties improved significantly, including improvements in mucus properties overall, and observations in qualitative reduction of its surface inflammatory cells and improvements of epithelial integrity, which we think are partially mechanistic for these improvements we saw at the microscopic level. Turning to the macroscopic level, we found, this is data from by Scott Donaldson and colleagues there, including Jennifer Goralski, in a recent publication. There's in fact increases in bulk mucus clearance shown here in the left-handed graph, which is a technetium-99 nuclear medicine scan that shows improvements in bulk mucus clearance and significant reductions in this study in percent solid, which is the measure of the overall hydration and mucus health in patients that are expectorating. On the right-handed graphs, you can see that in fact, looking at functional MRI imaging, that there was improvements in the ventilation score. And when drilling down on structural MRI in the bottom-handed table, we can see that that's likely due to improvements of airway wall thickening and bronchiectasis findings of the structural disease, as well as improvements of mucus plugging as another mechanistic insight into pulmonary disease. For the purpose of this talk, I'm considering that infection is also linked to pulmonary disease. So this is data from Pradeep Singh's symposium, which was given yesterday. I would encourage, if you weren't able to attend that, to look at that data in the background when you have time. This data shows that the quantitative cultures for key CF pathogens, including Staph aureus and Pseudomonas, rapidly reduce out to 12 plus months. So we'll see what this comes across as a clinical finding later as we extend this study out, but suffice to say that we're seeing very good data on reduction of overall quantitative amounts of infection in patients in the overall core cohort. In addition, we're hoping to find this will correlate with data from systemic and mucus level inflammation with biomarkers that are being analyzed at present by Scott Sagel and his group. And so we hope there'll be some correlations and data to come out from mechanistic insight on that standpoint. As I said, I promised that we'll talk about some stuff outside the thorax. I'm going to start with the endocrine and bone density results, which are also going to be presented in 2 symposia, as well as a workshop tomorrow by Mike Stalvey. So I invite you guys to attend all of these sessions, and this is top-line data from those. So the first finding that I want to highlight is we had improved fasting glucose rates and improved near-term glycemic index by the hemoglobin A1C. These were modest but statistically significant reductions. In addition, there was a modest but statistically significant increase in the insulin secretion rate from patients without established CFRD. So We posit that at this 12 to 18 month, this does not have effect on the development of CFRD. However, there are some initial signs that suggest we may have improvements of glycemic control in this cohort. In addition, in thinking about bone density, there was no discernible improvements in bone density in the older disease cohort at the same 12 to 18 month therapy timeline. However, we have many mechanistic insights that are still to come out of this. So I'm going to take some interim conclusions about these particular sub-studies. In these preliminary analyses, the 12 to 18 month clinically prescribed ETI patients, there was a lack of improvement of oral glucose tolerant OGTT-related glucose excursion, but there was improvements in insulin secretion and glycemic control, and there was increased C-peptide indicating increased insulin secretion. However, the effect on insulin secretion and glucose tolerance were prolonged, and the prevention and development of CFRD is an unanswered question. We hope to answer with the extension question. In addition, long-term data are needed to conclude an effect on bone density and especially the development of osteopenia as patients age and osteoporosis. Now I'll turn briefly to the GI results, which are coming out of both the PED sub-study as well as the overall, the older age cohort. And I hope you guys will take a look at some workshops and posters which have come out of this, as well as a recent publication led by Sarah Jane Schwarzenberg, recently accepted in JCF about the older age cohort with the GI outcomes. So there have been some surprising findings. We thought going into the study we were going to have a significant improvement in GI symptoms post-ETI. However, that has not borne out in the 6-month data. I'm just showing some kind of top-line data on this here. However, we have shown in correlation, though, that there are improvements in markers of intestinal inflammation like calprotectin, but no increases in fecal elastase, indicating there's not been rescue of exocrine pancreas function. This data from the PEDS GI study closely mirrors the 1-month data from the older PROMISE cohort in the publication I mentioned, and there's 6-month data in that publication I invite you guys to review, showing similar results to the 1 month in that manuscript. We've also begun to look at is there microbiota changes, because there's a hypothesis that improvements in the microbiota may improve inflammation in the gut, and specifically with correlations to the calprotectin decrease. So in this is data from the PEDS GI cohort. So preliminary, the answer that provided by the PIs was yes. In that, about 60% of children had a decreased fecal calprotectin at the 1 month mark in this sub-study. And of those that had a significant reduction that were started at abnormal levels, about 50% of those had normalization of that biomarker by one month, indicating they had gone from totally abnormal to completely normal during that time frame. Among those, there were some non-significant trends related to fecal microbiota, which include increased relative abundance of the firmicutes, which are apparently very protective against fecal and colonic inflammation, and reduced abundance of pro-inflammatory bacteria in that microbiota. So I think we're beginning to get mechanistic insights, and again, I would encourage you guys to look at those posters and ask those PIs additional questions regarding that, as some very interesting findings we hope to find in the future. So conclusion on the GI section, after 1 month of ETI, there was a report of some modest improvements in constipation, but variable improvements overall in overall symptoms. I did not show this data that there were varied effects of ETI on GI motility, and data that was not shown. The intestinal inflammation did improve by some modest reductions of fecal calprotectin, but there is not rescue of fecal elastase, indicating rescue of exocrine pancreas function. Unshown data show that liver enzymes did not change in either of these cohorts, and there's a significant amount of ongoing data in the stool microbiota studies and other sub-studies to answer more GI questions. So I'm going to conclude by talking about our long-term extension to provide a bit of the rationale for this and the progress of this extension study. So I'm turning back to our initial slide about PROMISE, and I was thinking about giving this talk and about presenting to the PIs and the TDN day, and I thought, gosh, when you think about just these few things, there are so many questions one can ask. This is just a list of some of my individual questions, and I thought to myself, gosh, if I have this many questions myself, there must be a ton of others. So our group of PIs got together and thought about an extension study with really thinking about wanting to answer questions like, are we going to mirror in a real-world setting the long-term effects shown or published recently from the long-term goal data looking at ivacaftor over the course of 5 years? Will we see those significant reductions of improvements of symptoms? Will we see that that trend towards reduction in lung function and stabilization to some extent, or slowdown of the decline of lung function and other of these findings. In addition, we'll be able to answer this question, and we'll be able to extend this study to answer other questions about the extrathoracic organ systems involved. And so the initial PROMISE investigatory period will not answer all of these questions, obviously, regarding the long-term effects of ETI on key pulmonary disease. And so we think we'll have to answer questions regarding additional visits with what will happen as patients age and other aspects of CF care change. Will the key pulmonary and clinical parameters remain improved after several years of therapy, as we've seen with the GOLD study and other real-world studies? And what's the long-term effects of ETI on infection and inflammation in patients with established lung disease? I think that's a key question. We hope to at least get some mechanistic insights from the PROMISE study related to lung disease. In addition, and perhaps as important, if not more importantly, will the GI, pancreatic function, nutrition, et cetera, and other extra pulmonary organ systems have improvements with longer-term ETI not fully observed in these initial studies, and can we answer those questions with extended visits? So here's how we're conducting that long-term extension study. So we've added on a visit 7 and 8, which will be a 36 to 42 month, and then about a 4 to 5 year follow-up visit, and a visit 7 and visit 8. And this would be similar visits with similar enrollments in the sub-studies I've outlined briefly today, with the idea that we can continue to collect data with prolonged exposure to ETI in this real-world study, and hopefully begin to answer these questions. Our progress today is that we've consented about 260 of our 460 initial patients. A subset of patients have not consented or withdrew their consent to go into the extension study, which we felt was a letdown to us. However, we're extremely excited we've had this level of uptake, which is mirrored about what happened in the GOLD extension study. And we still have over 100 patients who have not had their visit 6, where we're consenting most of these patients. So we think that if we have this continued enrollment at our current rates, that we'll have approaching 350 roughly patients in the extension study, really to begin to answer these type of questions. So then I'm going to conclude by saying that PROMISE has confirmed some key clinical outcomes from the pivotal studies, and really has begun to ask a lot more questions about mechanistic insights. We have some new mechanistic pulmonary insights. We have a lot more to do with those endpoint measures, especially with the extension study. And while there are more questions and answers remain on the extrapulmonary effects, we have certainly gained a lot of observations about these endpoint measures, and we think we'll add additional insights we see patients observed throughout the extension study with prolonged exposure. And so I'd really like to thank all the PIs and the patient participants in the trial, all the co-lead PIs, the sub-study PIs, the PIs and RCs, all the sites, and really a big shout out to the TD&CC team. They really keep us going and did an incredible job during the COVID pandemic, keep the study going in a real-world fashion. And then thank you to the CFF and other funding sources for myself. So thank you very much. I'm happy to take questions.
So feel free to put some questions in the app, or I guess if you can get up and speak loudly, we can also hear you. But if I have a question, Marty, that maybe we can start thinking about. Do you have any insights from the PROMISE cohort about maybe non-responders or hyper-responders to therapy? Because I think clinically we're certainly observing people that are either not having the same clinical outcomes that we see sort of on average,
right,
or those that have much more robust outcomes.
That is being analyzed, so that we definitely are thinking about that, especially pretty easy to answer this study about lung disease. I think we're going to have to learn more about the endpoints of the other disease, the other extrapulmonary effects to answer those questions. It's a little bit tougher since there's been more varied, but the lung disease, we're definitely looking at that. So hope to have those answers for you in the future.
One thing I was wondering, it seemed like as you were talking about gut inflammation, decrease in bacterial load in the lungs, and then even the endocrine findings, it seems to me that you're telling a good story about overall decrease in inflammation, right? We've been looking for anti-inflammatories for years in CF. Do you think that as we improve the overall health with patients with CF, are we going to see a decrease in systemic inflammation and other forms of inflammation?
I think that's absolutely a fantastic question. We have wrestled with that already. I think we obviously would like to see the blood inflammatory markers, what happens with that, and that's on the next steps for analysis from the initial and the longer term cohorts, and we'll go throughout the extension study.
We found some.
The other question we have is there an effect
a systemic effect from local improvements just from the lung disease, even if we're not seeing a huge response in the other organs, will there be a spillover effect from reduced inflammation from the lung disease having such significant improvements? I guess my kind of hypothesis is yes, we will, because we've seen that in other disease states. I think we'll be able to answer that question a lot better as we see how these biomarkers and the extrapulmonary effects morph over time with these patients, and also when we get that systemic, the blood and other inflammatory marker data back. So I think we're definitely trying to answer that, and I think the initial answer is we probably will see that if we can just show it. So it's a great question.
So Marty, there are a couple questions from the audience. Thinking back to our physician grand rounds cases yesterday too, is PROMISE looking at all mental health side effects or potential mental health outcomes?
I wish we had done that. So we did not design it. There's not a sub-study looking at neuropsychiatric effects. It's funny when I present this talk to the concept of PROMISE, when I present to people outside the CF world, that same graph that Dave designed that I put up at the top of one of the slides, I actually put neuropsychiatric above the head because I think it's needed to be looked at. And I know that I have heard and seen some posters and talks there that's being looked at the kind of the systemic level. And I think we need to understand the mental health consequences of ETI, both from a drug effect, is there a direct neuropsychiatric effect of the drug, and also is there improvements in mental health related to having improved health outcomes and whatnot. I know that's being answered by other studies, but not by the PROMISE directly.
Another question that came in is there any chance that some of the improvement in blood glucose control is because patients now have more time to focus on their blood glucose, i.e. they're doing less pulmonary treatments?
I don't think we have the granularity to be able to answer that question, but I'm going to invite you guys to go to the workshop talk tomorrow, because that's a little bit of insights into that. And to be honest, I think it's better if endocrinologists try to answer that question, because the concept of insulin monitoring and whatnot is a little bit foreign to me, to be honest, as far as being a pulmonologist. So it's a great question. I think it will be addressed, at least what we know at this present, at the workshop tomorrow. But great question.
And then there were a few questions that came in around some GI outcomes.
Sure.
I know there are other workshops about this, but regarding the data on fecal elastase, was there a look at those who started out with different levels of varying fecal elastase, those that were pancreatic sufficient versus insufficient at onset?
The majority of patients were insufficient at onset due to the nature of their illness, and that is being looked at as a subgroup analysis. I don't have that data, though. It is being looked at.
And then
I don't know if we're going to be able to tease it out fully from what we have at this study, but it's a great question. But it is being examined as best we can.
And then the last question, again, goes back to the micro data. Do you think that this data is starting to suggest that we may have an eradication strategy by the use of modulators as opposed to antibiotics?
So, mind you, what we know now is that there's the quantitative level of infections reduces in the adults at a prolonged period of time, and we know that in the peds there certainly appears to be less quote-unquote positive cultures. So I think it depends on how we define eradication. If you define it by qualitative, I think it's likely there will be patients that fully eradicate, and that's really why we need to have this, one of the very good reasons to have an extension study to really be able to answer that question over a long period of time. My sense is from a qualitative kind of clinical infection standpoint, based on routine microbiology, there will be a lot of patients that eradicate. Whether or not they'll eradicate with fully negative cultures that are just undetectable, if you go to a quantitative type culture, I think it's a whole different question we'll be able to answer with these type of endpoints.
Thanks, Marty, and thanks for this great presentation.
Great. Thank you guys very much.
So our next speaker is Dr. Dave Nichols from the TDN Coordinating Center, who is going to present to us the results from the Simplify study.
Reading glasses, developmental milestone. Great. It's a real privilege to be here and present the results of Simplify with you all. Here we go. Here are my disclosures. I don't know that any are particularly relevant. So on behalf of my study co-PIs, Nicole Hamblett and Alex Gifford, it's a privilege to be here, and we are going to share with you the results of Simplify, which is really two parallel trials in one, testing withdrawal of Dornase alpha or hypertonic saline in those on highly effective modulator drug therapy, in this case, ETI. Very briefly, just to remind us all of the rationale for why we did this study, it's commonly understood that treatment burden is a leading research priority, not only for people with CF, but for many providers. And ETI introduced highly effective CFTR modulation to most people with CF in the United States. Dornase alpha and hypertonic saline are also very commonly used in the US and commonly identified as burdensome parts of daily therapy. Importantly, they work downstream of the manifestations of CFTR dysfunction in the airway. And so it's possible that substantial, though incomplete, drug-induced restoration of CFTR will mitigate the benefits of therapies like these. When designing the study, we asked a large number of people with CF and their families, as well as clinicians, what would be important to understand if we were to test withdrawal of therapies in the context of ETI. And there was quite a bit of overlap, which is good to see. Drops in lung function and increase in daily symptoms were key concerns. Also a need for antibiotics, perhaps a little more so among clinicians than those with CF. We also went back to the rich publication resource in these two therapies in CF to ask two key questions. First of all, what time period is needed to capture a change in FEV1 or the lung clearance index? And in retrospect, the question is 6 weeks long enough to measure any change after discontinuing therapy? The second question is, what were the smallest effects we've seen in these outcome measures and those with the least advanced or really normal lung function in regards to FEV1? And should these change in those who start with a normal baseline? So I wish there were time to walk through each of these studies with you and show you the remarkable consistency, but I'll summarize for you and encourage you to go back and review these papers at your leisure. FEV1 and LCI maximally improve within 1 to 4 weeks after starting either Dornase alpha or hypertonic saline, and they return to baseline or decline within 2 to 4 weeks after discontinuing either of these therapies. With Dornase alpha, FEV1 changes as small as 3 to 4%, and LCI change as small as 0.9 have been reported in very young children who had normal lung function based on spirometry. And with hypertonic saline, LCI change as small as 0.5 was recently reported in young children, even with minimal or no change in FEV1. So we have some context for what we may look for. So this was a study design in Simplify. As mentioned, it's really two parallel clinical trials in which people were randomized to either continue or discontinue that inhaled therapy for a 6-week period with close monitoring and follow-up. Importantly, what I want to draw your attention to here is to be randomized. There was an intense 2-week screening period where individuals who wanted to be in the study had to demonstrate clinical stability and an ability to comply with daily reporting on the therapies they were using. This was through their personal electronic devices. They also had to show us that on those days they were reporting, they were highly adherent to therapy. It's critical in a test like this that we understand we're measuring two different groups, those using or not using those therapies, and these therapies remained available at home, so that's even more important to make sure we understand what people are doing or not doing. Our study endpoints are these. Our primary outcome, the absolute change in the percent predicted FEV1 over that 6-week period. And then secondary outcomes importantly included lung clearance index, which is a more sensitive measure of change in lung function, especially in individuals with normal FEV1. As you would guess, self-reported symptoms, respiratory symptoms, including the CFQR respiratory domain and the CRIS scores, the need for antibiotics or hospitalization, and a protocolized definition of exacerbation. And then we monitored safety, including adverse events reporting throughout the study. There's a translational sub-study that was done that had focused on the mucociliary clearance scans that were just mentioned in the last talk. Briefly, before we move to the results, I want to remind everyone this was a non-inferiority hypothesis we were testing. In other words, we weren't looking for just changes between the two groups, those who continued or discontinued, but rather we wanted to see if those who discontinued would not be substantially worse than those who continued their therapy. So to do this, you have to have a predefined non-inferiority margin. With a lot of input, this was defined at a minus 3% change in percent predicted FEV1. And so that what that means is we need our 95% confidence interval to clear that boundary to declare that this is not inferior. What that really means is that the effect size shown in the blue dot would be pretty close to 0. Just briefly, who did we study? So we included those aged 12 years and older who had been using their ETI for at least 3 months. It turned out that about 2/3 of people who were enrolled had been using their ETI for a year or longer. They needed to be using their hypertonic saline or Dornase alpha for at least 3 months. You can imagine in most cases that was several years. We intentionally recruited a fairly healthy population as a first big randomized trial in this space. So everyone had to have a percent predicted FEV1 of at least 60%, and adolescents had to have an FEV1 of at least 70%. They needed to be clinically stable, and as mentioned, they had to demonstrate this ability to comply with med use reporting and adhere to their assigned regimen. So with over 1,000 screening visits during the pandemic, 850 people were randomized, including nearly 600 unique individuals who participated in one or both of these studies. You can see how it broke down in the 2 trials. Some more were enrolled in the Dornase alpha trial. That's because there were more people who came into the study using Dornase alpha alone, as opposed to hypertonic saline alone. And I'll just draw your attention to the last section there at the bottom, the per protocol population, which was about 75 to 80% of all those in the study. When you consider non-inferiority, this is actually our primary analytical population where we're most conservative about trying to identify a difference between the 2 groups. But we'll show you the intent to treat results as well. The participants at baseline were on average 22 years old across the both studies, hypertonic saline on the left, Dornase there on the right. Their baseline FEV1 was 97% predicted, which I think is very encouraging overall for several reasons. You can note there at the very bottom, their post-ETI sweat chlorides were in the 40s. This highly adherent group we recruited, they also were common users of airway clearance therapies, such as VEST or PEP, et cetera. And based on the modulator they had used prior to ETI, we can probably correctly estimate that about half of them were F508 homozygous individuals. Note there too that in the hypertonic saline trial, roughly 85% were also using Dornase alpha. In the Dornase alpha trial, just over 60% were also using hypertonic saline. So we focused for good reason on this adherence and compliance, and I just want to point out how excellently the participants performed in this regard. Their compliance to reporting was 90% roughly, so 9 out of 10 days during the period they provided us these data, and their adherence to their assigned treatment to use or not use a certain medication in the study was over the 95%. ETI use was approaching 100%. Obviously, this is not reflective of necessarily real-world use, but in this focused 6-week period, they did an excellent job of being careful about what we asked them to do so we could really scrutinize whether there's any effect here. Okay, let's move to the results. So this is our primary outcome, the 6-week change in percent predicted FEV1. First, in the hypertonic saline trial, those randomized to continue hypertonic saline had a 6-week change of minus 0.37%. Those randomized to discontinue, minus 0.54%. In the Dornase alpha study, those randomized to continue, minus 0.13%, to discontinue, roughly 0 or no change. We put this back in context with the non-inferiority margin, set at minus 3% ahead of time. You can see that our confidence intervals easily clear that margin, suggesting that discontinuing was non-inferior to continuing in regards to this primary outcome measure. That's true for the per protocol population and also the ITT populations below. Let's then move to important secondary outcomes. Briefly, I'll show you a little more data, sorry. The individual responses through the waterfall plots we wanted to show you, just to demonstrate there's no grouping in one group or the other, discontinue or discontinue across these areas, and remarkable stability. 80% or more stayed within 5% of their baseline FEV1, which is within the margin of error for this test, and it did not differ between the 2 arms in either trial. Because this is our primary outcome, we conducted significant subgroup analysis to say, is there perhaps a subgroup who really is an outlier in this regard? And what we can say is there was impressive consistency across the subgroups. So with respect to sex at birth, age, baseline lung function, whether they came into the trial on one or both drugs, et cetera, it didn't appear to make a difference in regards to our primary outcome, change in FEV1. There are a couple of groups that are relatively small. The confidence intervals expand both directions broadly, but that has to do with the size of the cohort. Now we'll move to important secondary outcomes, and credit to Dr. Felix Ratchin and the LCI NRC in Toronto and all the study sites who provided these additional data for the study. So this is the LCI 2.5 measure. I want to point out that the group here, it's actually a pretty large LCI study, mean age of 20, a little bit younger than our overall cohort. FEV1 similar, but a few points higher. Baseline LCIs were around 8. So with this software and this group, an abnormal LCI would be above 7.1. So these are abnormal at baseline. But what you can see is in the per protocol and ITT populations, the change in LCI was near 0, and the confidence intervals around that cleared the smallest effect we've seen with hypertonic saline, which was in the 3 to 6-year-olds in the SHIP-CT study, obviously without modulator drug therapy in that group. In the Dornase alpha trial, very similar. So virtually no change, confidence intervals easily clear, that 0.5 margin, smallest effect previously reported. Moving then to self-reported respiratory symptoms. This is the CFQR respiratory domain, where an MCID of around 4-point change has been suggested, albeit in other contexts, not withdrawal studies. But you can see there's very small change in this self-reporting of respiratory symptoms during the period. And the same was true for the CRIS, where the MCID and maybe around 11-point change, easily cleared. Let's move then to safety. Glad to see very few pulmonary exacerbations in this group, just a handful and no real difference between the two groups. Acute antibiotics use for any reason was actually relatively uncommon. If we move then to all adverse events, there is some suggestion of a difference here, wherein those randomized to discontinue either their hypertonic saline or their Dornase alpha had a few more overall adverse events identified. You can see on the second row there, 25% roughly versus 35% roughly in the two trials. But I want to call your attention to the fact that the large majority of these were mild or perhaps moderate, over 95%. And treatment modifications or changes, even in an open label study, were very rare. We did have one adverse event that was identified in over 5% of a group assigned to discontinue with therapy. 5% is a common threshold to even report adverse events in trials. We've gone down to 2.5% here because we had so few and wanted to be more transparent. But cough was identified in 6.7% of those randomized to discontinue Dornase, compared with 4.2% randomized to continue that. It's a little difficult to put this in context, but we're going to try. So this is a recently published 8-week study. Again, we had a 6-week study of those who had an IVA-responsive mutation, and there was an active control arm, those who remained on their IVA or TEZ-IVA. You can see their sweat chlorides were below 60. They were older, had a lower FEV1 than our cohort here. But just to point out, any adverse event was identified in 65% in that study, in that group. Cough identified in 14%, and exacerbations in 10%. So the overall rates of AEs in this study were remarkably low. If you dig a little deeper, though, there is some suggestion, or at least something to take note of. So those who came into the study on the lower end of our enrollment criteria in regards to FEV1, between 60 and 69% are predicted. You can see the numbers we enrolled in that group there at the top, but there is a differential relative increase in some sort of AE identified in both trials, and we want to call attention to that. Let's then move to this mucociliary clearance translational substudy that was performed. Again, this is a nuclear medicine study that Marty just drew your attention to in the PROMISE study, and we want to give big credit to Scott Donaldson and the MCC sites. This is a pretty heavy lift, and to pull this off, we're very appreciative of, and it was worthwhile, as you'll see in a moment. So they were able to enroll 17 participants in each of the two trials. They were randomized to continue or discontinue hypertonic saline or Dornase. They were a little older and had a lower FEV1 than the overall cohort, as you can see there. A primary outcome of interest is the change over 6 weeks in the whole lung 90-minute clearance, a percent of clearance over 90 minutes. So the hypertonic saline study, many of you will recall the 2006 New England Journal of Medicine publication led by Dr. Donaldson, showing MCC improvements with hypertonic saline. Here, those who discontinued hypertonic versus continued had no difference in their 90-minute MCC lung clearance. In the Dornase trial, however, there was a difference. However, it was unexpected. Those who were randomized to discontinue the Dornase actually had an improvement in their 90-minute lung clearance over the 6-week period. Those who stayed on their Dornase had no change in their clearance. And most of this was actually peripheral lung clearance, which is where we've seen MCC changes with systemic drugs like ETI. In fact, all the participants who were randomized to discontinue their Dornase saw improvement in their 90-minute clearance over that 6-week period. This is hypothetical, of course, but it suggests that perhaps people on ETI are starting to respond to medications similar to those with non-CF bronchiectasis, where Dornase alpha was shown to be ineffective. So to summarize our findings, stopping either hypertonic saline or Dornase alpha was not inferior to continuing therapy as measured by our primary outcome, the 6-week change in percent predicted FEV1. And that confidence in that interpretation is increased by the consistency we see in analysis populations and across subgroups. No clinically meaningful change in LCI occurred as well, and no clinically meaningful change in the respiratory symptom scores, antibiotic use, or hospitalizations were seen in these trials. For those who are more data-driven, we wanted to pull this together to give you a chance to pull up your phones, apparently. Draw your attention to the outcomes on the left, the MCIDs, or our non-inferiority margin set there in the second column, and then the relevant confidence interval. We actually designed this around the primary outcome, percent predicted FEV1. We did not expect to be able to see non-inferiority across the other outcomes, but that occurred. There are important limitations beyond even those I can discuss here in the 20 minutes, but we want to call your attention to a couple of those. So we recruited a healthy population. That was intentional. This may not predict what would happen in individuals who are not reflective of the group we studied. And that AE data may highlight some potential concerns even in the lower end of the group we studied. I think that's worthy of consideration and further investigation. I won't go into the details, but we weren't able to blind or monitor adherence through, say, chip nebulizer devices in this trial. So we worked with the STRC and others to enrich for a highly adherent and compliant group. That may predict that they do particularly well with other parts of their therapy. We don't know, and that may be important to consider in interpreting these results. And we look forward to greater insights from QUEST, a parallel study that has been highlighted several times at the meeting. I encourage you to look more into that. I think it's also important to know that we didn't stop their airway clearance therapies. We stopped an inhaled therapy. And so in considering the perhaps implications of this, that's worth noting. We monitored lung function changes over 6 weeks. That was necessary to identify and collect this highly compliant and adherent group so we could be confident in what we were testing. Studies prior to ETI indicate that this is an acceptable time frame to see changes, but we have to recognize that we didn't monitor for longer, and so perhaps delayed or slower changes could occur. We just can't say. And this wasn't a study we would design actually to look at exacerbation risk. So it's possible that an independent effect on risk of exacerbations may still be present. And we look forward to important other studies that are ongoing. You'll actually hear more about here in a few minutes. CF Storm in the UK, Hero 2 here in the US. And I think all of these data together will help us make the best decisions with our patients. So in conclusion, among adolescents and adults with relatively good lung function on ETI, discontinuing daily use of either hypertonic saline or Dornase alpha did not result in a loss of lung function or increase in daily symptoms. It is our sincere hope that this and ongoing studies will support shared decision-making between clinicians and those with CF on ETI regarding certain daily therapies, with the overall goal and theme of this work to reduce treatment burden. I'm very grateful to Nicole and Alex, of course, and Nicole for leading this work, our collaborators and steering committee, DSMB, the CF Foundation for funding, quite a large project, and our study team, all of whom were critical, especially at crunch time, to get all these data together for the meeting. Most importantly, to the 80 Simplify sites and all those with CF who conducted a very large trial in very difficult times, and I hope everyone feels gratified with what we've done. I'll also mention that we went through a lot of data, and I'm pleased to say that publication is imminent. You'll hear more about that actually later today from Dr. Hamlet during the plenary, and so you'll be able to sit with these data and think about them a little more. Thank you very much.
So, Dave, as expected, there are a couple of questions that are coming in. The first question is sort of a clarification maybe, or maybe you have some insight on, were there differences in those who started out on both therapies and then withdrew one in either of the trials versus those that were only on the one therapy and then withdrew?
Yeah, so the question is, did it matter whether they came in on both therapies and then randomized to withdraw one or not, or versus one? And in subgroup analysis, we showed very quickly that didn't seem to make a difference, whether they entered the trials using both therapies or one. We will scrutinize those data a little more, including those individuals who participated in both therapies sequentially and may have withdrawn both therapies sequentially. We don't have those results yet, but at a high level, it did not appear to differ for those, at least in the primary outcome of FEV1.
Another question, was there any concern that patients who were asked to discontinue one of their medications, were they sneaking them in, taking them inadvertently, et cetera?
Yeah.
I know,
Yep.
people taking more medicines.
Yeah, no, that of course is a concern. At some level, there's an element of trust here, right? I think we're learning a lot from Quest. I'm grateful that I've seen some of the early results. The themes when they interviewed a number of participants in the study around what was their reaction to being randomized to continue or to discontinue in general. The reaction when they were randomized to discontinue was they were happy about that, and to continue they were actually a little bit disappointed. So we can't know with certainty. I would be a fool to say it never happened, but I think for the most part, we're confident that the accuracy and the reporting and the very high reporting and some nuances in those data I won't go into indicate that they were honest and accurate in that reporting.
Another question, are there any plans for an extension on the Simplify study to follow this cohort on a longer period of time?
Yeah, there are no plans for a formal extension study, but as with virtually all studies in the TDM, we collect the CF registry numbers, and so that will allow us to go over time in the future and assess their clinical outcomes longer term, and that is part of the plan going forward. That'll take some time, as you may guess.
Two sides of the same coin. You have a very compliant, relatively healthy group. So how do you think that potentially influenced your outcomes? And the flip side, is there any plans to look at maybe a less healthy or less adherent group?
Yeah, it's a great question. Before I answer that one, Cindy, I need to correct myself on the last answer. So we aren't formally following the Simplify cohort in the randomized kind of fashion. There is an important 24-week follow-up in Simplify where every 4 weeks we're asking them on their personal device, what did you choose to do? We want to understand what people chose to do with these therapies after the trial. So for about 6 months beyond, we're going to collect those data and whether or not they needed any antibiotics in the last month. So the last of each month. So there will be some important data. Alex will be leading that work and we look forward to that. Sorry for the oversight. Yes, of course. I think it's an obvious next step to consider, well, what about those with lower lung function? And we have actually enrolled. We opened up in the middle of the trial through DMC approval, looking at the interim data. We were blinded. They were not. They allowed us to open up a lower lung function cohort, 40 to 60 in adults. That did not enroll very well, and we're not entirely clear why. It could be that a lot of people had already decided what they were comfortable doing or not doing without data. We enrolled about 25, so we won't have a lot of power to to understand that. If those results are entirely consistent with the older group, maybe there's something there. But anyway, that's to be determined. None of us have seen those data yet. I think that begs the question, particularly I think with the mucociliary clearance data with Dornase, I think it's fascinating to ask whether those with lower lung function have a similar response to those that we studied here.
So, Dave, thinking beyond the trial, which I know you've provided some very robust data on a short-term effect here, but we all know that people will look at this data and start making clinical decisions based on that. And there are also maybe some financial implications. So one of the questions that comes up is there any concern that given this data, payers or insurance companies might start questioning the need for some of these chronic medications?
I guess there are two. So the question is there concern about availability or maintaining availability if people choose to stop daily use of either therapy? It's a really important and insightful question. Point I didn't make for sake of time, but it's my opinion, our opinion, in thinking about it, even if people discontinued or interrupt daily use, I think it's likely they'll still benefit from these therapies when they're more symptomatic or perhaps they're in exacerbation. I think that's an important research question. So maintaining access to these therapies and the equipment to use them, I think, is an important part of the conversations should you and your patients decide to modify daily use. It's also important to say we don't have all the answers yet, right? There's a group of studies coming together to try to deal with how best to help people balance daily treatment burden and preserving or maintaining their health. And so we have other data that we're awaiting for and ongoing important studies that will help us get there. So these are highly individualized decisions. I also recognize a lot of people have already made these choices without any data. So perhaps that's a different nuance to the conversation. Perhaps there's some reassurance for them that can be provided with what we've seen here. Thank you very much.
Well, that was very exciting to see this data. And now I'd like to welcome Dr. Gwyneth Davies to the stage. She comes to us from the UK, from the UCL Great Ormond Street Institute of Child Health, and she's going to talk about the UK study CF Storm.
Thank you very much for that introduction. I'm delighted to be here in Philadelphia to talk to you today on behalf of the CF Storm team. Here are my disclosures. And I realise I'm following Dave Nichols' talk, so I perhaps don't need to go over the background as to the kind of driver for this sort of trial in so much detail. But similar to the US and the UK, we recognise that people with CF obviously have a high daily treatment burden, taking around 2 hours a day with multiple medications. As in the US, our patients are commonly on nebulized therapies. Over 80% of our patients in the UK Cystic Fibrosis registry are on at least one nebulized treatment, commonly more than one. And the phase 3 trials of CFTR modulators have been conducted in addition to usual care. So that is on top of existing treatments that people are on at enrolment. And as we've heard from Dave, the treatment burden is a real research priority. And that's been particularly heightened now in this era of CFTR modulators with increasing interest in the concept of stopping trials or treatment withdrawal trials. And that's where CF Storm comes in. I'm delighted to be co-chief investigator for this clinical trial with Professor Kevin Southern. Unfortunately, he can't be with us in Philadelphia today. The CF Storm trial is looking at the research question, can people with cystic fibrosis established on elexacaftor, tezacaftor, ivacaftor stop nebulized mucoactive drugs without a significant fall in their respiratory function at 12 months? And I just wanted to go over the ethos and rationale for this trial because it's really been driven by community engagement, and that's been a key theme really from the start. It's obviously addressing the priority that's come from the patient community about how can we reduce treatment burden? Can we make daily life better and not compromise health by doing so? We had a lot of feedback from our patients that to do a trial that was looking at treatment burden and see if we can reduce treatment burden, that trial shouldn't be burdensome in itself. And therefore, there was a driver to have a low-burden clinical trial to try and address those questions. We were designing this clinical trial in the context of the COVID-19 pandemic, and there was feedback from our patient and clinical community that it was important to have a trial that could be delivered remotely if required. We had a clear steer to focus on nebulized therapies because they were considered particularly burdensome, but people were happier for us to have an intervention that was focused on withdrawing mucoactive therapies, so Dornase alpha and hypertonic saline, rather than inhaled antibiotics, because there was more resistance to having that as an intervention in this sort of trial design. And really what we wanted to do with this trial was provide an evidence base for people to make their decisions about treatments, both for patients and for clinical care teams. And I wanted to share with you a video from a man called Simon, who's living with cystic fibrosis, just on what his thoughts about the trial and CF Storm. Hopefully this plays okay.
Future ones, I think I could split it into two for me personally. I think because of how well I feel and how stable I now feel on Kaftrio, for me, I would like to be involved in research like CF Storm, where my clinic is very, very paranoid about anybody coming off any current treatments because there's no evidence. So I think we need to do trials which look at DNAs or look at, prophylactic antibiotics, or whichever bit of the treatment burden it is, to see whether the effect is significant anymore or not. Because although anecdotally I can say I ran out of drugs for 6 months and felt no difference, the clinic wants real data. So I would quite like to get on CF Storm or something like that, because I think for the people who take Kaftrio, that's probably one of the more important things at the moment. Future.
So fitting in with that ethos and that driver from the community to have a low-burden clinical trial, we wanted to harness the potential of the Cystic Fibrosis Registry in the UK to deliver such a trial. And for that, we were able to build on some work that's been done for a trial called CF Start, which is an antibiotic prophylaxis trial involving infants with cystic fibrosis. And this is a trial that's been running in the UK for the last few years, whereby infants are recruited and randomised on the Cystic Fibrosis Registry, with all outcomes collected on that. So in the UK, our registry captures data on over 99% of our UK population, and we capture annual data, but also there's a functionality for capturing all encounter-based data as well. So building on that for CF Storm and fitting in with that idea of being able to remotely deliver a trial, we integrated functionality for having patient-reported outcomes and patient surveys, which could be directly incorporated into a trial-specific study module for CF Storm, which could also pull data from the core registry, and also a process for electronic consent, whereby that process didn't need any sort of wet signatures done in the clinic. It could all be done electronically via a form sent by email, etc. So the study population for CF Storm is similar to the Simplify study population, but important differences including we have a lower cutoff for our minimum FEV1 % predicted at enrolment down to 40%. We excluded people that were on mannitol because of, firstly, the proportion of patients on mannitol in the UK is not high, and it's skewed towards certain centres and not uniformly distributed, and also we didn't want to interfere with the key question that we were asking. And the intervention that we have, if people are randomised to stop, they withdraw the combination of mucoactive therapies that they're on at enrolment. So if somebody's just on Dornase alpha and they're randomised to stop, they just stop their Dornase. If they're on both Dornase alpha and hypertonic saline and they're randomised to stop, they stop both. And similarly, if they're just on hypertonic saline, they just stop hypertonic. And the comparison is with standard care. Our outcome is change in % predicted FEV1 between baseline and trial end at 52 weeks. And we're collecting secondary outcomes also on the Cystic Fibrosis Registry as listed here, including other lung function measures, pulmonary exacerbations, respiratory cultures, and generic and disease-specific quality of life measures. Similar to Simplify, this is a parallel arm randomized controlled trial with a non-inferiority design, and we, as Simplify, have used a 3% non-inferiority margin for that. Our sample size for this trial is larger than the arms of the Simplify trial, partly reflecting that this is a pragmatic registry trial, and we've based our standard deviation for FEV1 on the real-world ivacaftor data for the sample size estimates for our trial. So we are aiming to recruit 764 patients for our trial. And as I said, the ethos of remote participation being possible has several elements to it. So we have the e-consent, as I've described previously. We have the functionality for patient-reported outcomes to be captured remotely. And also, patients have home spirometry devices. So if people were recruited in the home rather than the clinic setting, we allow home spirometry for the primary outcome measures, but if that's undertaken at home, we require 3 measures over a period of 5 days rather than just a single FEV1 measure if done in the clinic. Also, it's obviously key for this sort of trial design, also as alluded to from the Simplify results, that it's important to understand whether these arms of the trial are really different. And we've done that in a number of ways to try and check that the people that are randomised to continue, if they are actually doing that, and indeed what's happening to those that are randomised to stop. So our participants get an automatic email sent out every 3 months to ask whether they're still, if they've been asked to continue their nebs, are they still continuing them? If they've been asked to stop, if they are still complying with that. And similarly, clinical teams document that when they see their patients in clinic for each clinical encounter. We also have quite detailed recording on our cystic fibrosis registry of start and stop dates for chronic medications. And in patients in whom there is existing measures for electronic data capture for their nebulized therapies, we're capturing that data on the cystic fibrosis registry as a measure of their adherence. So this includes people that have an iNeb device, which is capable of download, and also participants that are enrolled in CF Storm that are part of the CF Health Hub program, whereby people have a chipped nebulizer device that is capturing their objective measures of adherence for all nebulized therapies. So just to walk through the design of the trial, so the patients are sent an email from their clinical teams with a link to the study website, and that's where you can watch videos about the trial and you can download the patient information sheets for it. That's undertaken outside the cystic fibrosis registry, but once people are interested and want to take part, all other activities are undertaken within the registry itself. So that includes confirming the electronic consent, triggering the automatic emails that ask about the quality of life measures, collecting the outcome measures, and randomization on the registry itself. And then during the follow-up period of a year, the interim data from the clinical encounters are completed on the registry, and participants are sent measures asking about that trial allocation, as I've just alluded to, and also generic quality of life questionnaires at certain time points throughout the trial. And then they have a final follow-up visit after a year. So CF Storm opened in the UK in July 2021, and we're now open at 33 sites across the UK. Haven't quite got all of the UK map on this site, but we do have on this map, but we do have all the sites identified, and we've got sites open in Scotland, Northern Ireland, England, and Wales. Both a mixture of paediatric and adult sites that are open. Our first participant was randomised to the trial in July last year, and we've recruited over 1/3 of our target sample size, so we've recruited 277 patients, but as you can see, we're still some way off our target sample size. So in terms of key opportunities and achievements that we've achieved in CF Storm, this is quite an innovative trial hosted on the registry with the functionality of randomisation, electronic consent, this capturing of different outcomes. And it's really sort of moving the field forward in terms of how we can deliver this sort of trial. One of the key differences with the Simplify trial is obviously that, asking our research question over a longer period of time. Our primary outcome measure is at 12 months, but by capturing this information on the registry and doing this, all the follow-up on the registry, we can have long-term follow-up on these participants, including what treatment decisions people might take after the follow-up of the trial period. Also, the pragmatic nature of this trial is really in line with the ethos of the Cystic Fibrosis Trust and the Clinical Trials Accelerator platform supported by the CFF in terms of widening access to clinical trials and trial participation and having a trial that is accessible to people across a number of CF centres. It's fair to say that it hasn't been an always straightforward ride. We've had quite a lot of challenges. Some of these are ongoing, some of these are resolved. Stopping trials in the UK are considered clinical trials of investigational medicinal products. So even though we're taking away medicines, the regulatory framework is as if you're adding a new therapy on. That's obviously quite challenging in terms of thinking about adverse reactions and pregnancy reporting and other sort of features that are common to a sort of incorporating a new drug into therapy. But when you're taking it away, some of the framework for doing that sort of follow-up, particularly within the context of a registry trial, is quite complicated. By making the trial COVID-proof and allowing the trial to be remotely delivered, we move forward quite rapidly with progress in the cystic fibrosis registry with the modules and the data capture for that. But we encountered some significant technical issues with that, particularly a whole world of emails and email servers and not getting into people's inboxes when emails are sent from the cystic fibrosis registry system. And that's now all resolved, but that did cause problems last autumn. And also, as I showed, we've recruited a third of our patients, but we've got 2/3 to go, and recruitment is steady to our trial, but it's been slower than anticipated. And part of that probably reflects that we've designed a trial that is very nice and easy for patients to participate in, but it's still an additional challenge for clinical care teams to integrate within their clinical practice. And we acknowledge that there's an extra ask of those teams who are already stretched within the delivery of routine care. We also know, as alluded to in the Simplify talk, that patients are making their own treatment decisions. And that has impacted on the patients who may have been eligible to take part in the trial but are not, because they've either decided that they don't want to take their nebulized treatments anymore or are taking it so infrequently that it wouldn't be appropriate for them to come into the trial. And also encouraging teams to enter data onto the registry in a timely manner. That's obviously important because we're capturing all our outcomes, including safety data, on the registry itself, but timely recording of that is important, and that's another sort of ongoing challenge. So in summary, CF STORM is an innovative randomized registry trial addressing the research priority of reducing treatment burden. It's the largest actively recruiting trial in the UK at the moment for people living with cystic fibrosis. And as I said earlier, the involvement in the cystic fibrosis community has been really key to the design and the ethos of this trial, and we have really strong involvement from our community members working straight through the trial with us, both on our trial management group and also on the oversight committees for the trial. And in conjunction with the other studies, the results of CF STORM will help people make informed decisions about their nebulized treatments in this era of highly effective modulated treatments. And we see CF STORM as playing a key role to complement the results of the Simplify study by providing that longer-term perspective, and also in conjunction with HERO2, which is also looking at outcomes over a similar time period, to really have this evidence base where we can help people make their decisions about their treatments. I'd like to acknowledge all of the people that are listed on this slide, and also the site PIs and research coordinators at our sites across the UK. We have a study Twitter account. You can follow us on the CF STORM study if you're interested in hearing progress updates about the trial. And I've put my contact details and also Professor Southern's contact details on the slide, and our trial manager if anybody wants to find out more. Thank you for your time, and I'd be delighted to take any questions.
Thank you so much for a great talk, and we look forward for the future to actually see the results, hopefully, in the next several conferences. But there have been a couple of questions, and I think first to just ground those of us in the US to understand what the current status of access to ETI is in the UK, as well as sort of logistically, how do individuals who are getting Kaftrio obtain the medication? Is it through a centralized set of pharmacies? Do you have access to getting those records, as well as their other CF medications?
So in the UK, we have access to triple combinations, the FTR modulator therapy via our National Health Service for people that are age 6 and above. So that is, we are not collecting information on medicine possession ratios or detailed prescription data on Kaftrio or indeed Dornase alpha or hypertonic saline for this trial. But in terms of access to medications, we don't have the same issues in the UK as the US in terms of access to therapies.
So this is my question. You were talking about where you are with recruitment and struggling to meet your recruitment goals. And you did mention that patients are making their own decisions and may not be wanting to be randomized. Do you have any sense for how many patients are actually stopping outside of the context of the trial? Do you know from your registry?
So interesting when you look at the registry data for 2021, which was just published a few weeks ago, the number of people that are documented on being on hypertonic saline, Dornase alpha, or inhaled antibiotics has really not shifted very much at all from the 2020 registry data. But obviously, anecdotally in the clinic, and particularly the teenagers that I see in clinic, a lot of them have decided to self-rationalize their treatments. So we acknowledge that there's at least a delay and a degree of underreporting in terms of what we see in the registry data. So I think that the studies that are going on that are looking at objective measures of adherence and actual rates of treatments, and the HERO2 study is another example of we can actually see what's happening with these treatments in more real time. And we'll have information about that from the STORM study as well by capturing the start and stop dates of other treatments.
The electronic adherence data is obviously very interesting and will be intriguing to look at. Do you have a sense in your currently enrolled cohort, or also more broadly, what percentage of participants will have that type of data available and use the electronic monitors?
I don't yet know what proportion that do have that functionality available.
And then
but
a final
shout out to anybody that's in a centre that does have Health Hub or INEB recording, that we would be delighted to get that data on for our trial, because it is really important for us to understand.
And since this is all remote monitoring, what is the plan for handling missing data, and how often do you have any sense how often we're encountering missing data at this point?
So missing data is a real issue, and that comes back to one of the challenges that I mentioned on the slide in terms of the timely sort of data entry onto the registry for this sort of trial, because it's knowing whether the data is actually missing or whether it's just that the clinical teams haven't yet put the data on the registry. And we have sort of annual time cut-offs where registry data should be put in each year, but that obviously doesn't completely fit with the ethos of capturing data on the registry system. So that's absolutely a challenge that we are facing, and then we're working with sites to try and get that data on more timely so that we can work out if the missing data is truly missing or not.
As you mentioned, this is a pragmatic clinical trial, and it comes with certain limitations and also some strengths. I'm wondering if you've given any guidance to the clinical teams at each of these sites about what to do with participants who are enrolled. Do they know who's enrolled in CF Storm at their site? Are they given any parameters when they can restart somebody on therapies or recommend restarting? Do they know the randomization, or are they blinded? Clearly the subject is not.
Yeah, it's open, and the patients are recruited by principal investigators or sub-investigators at site, so the clinical teams will know who's in the trial or not. But if somebody's randomised to stop, it's completely within the remit of the clinical team to go with clinical decision-making to restart a therapy, whether that be short-term or long-term, but we would follow the outcomes up. So we're capturing that, both short-term and restarting medications within our long-term data capture as well.
And can you comment a little bit more about how the remote consenting process has been going for the trial?
So we had some really quite significant early technical issues whereby people weren't actually even receiving the email. So that was obviously really tricky, both for the patients and also frustrating and time wasting for the clinical teams involved as well. But now that's been completely resolved and it's working well. So essentially what happens is that if a participant is interested in taking part in the study, they allow their email address to be put into the Cystic Fibrosis registry, and that triggers an email sent to them with the consent forms for the trial. Once they've completed their name, that then automatically comes through to the registry, and the investigator puts their name on it to confirm consent, etc. So it's a process that's working quite nicely and can be done either with a smartphone or a computer in clinic with you, or can be done over the telephone with your participants sitting at home. So it's quite innovative for a clinical trial of an investigational medicinal product to have that sort of electronic consent process. So I think some of the take-home messages from my talk today, even though I'm not presenting results, it's just that sort of learning that we've gone through as part of this registry trial to look at this question of being important learning for the community in general as well.
And I'm going to take my prerogative as chair here to ask a question about the home spirometry that you're using. As you know, there are some trials that are starting to look at the use of home spirometers as clinical research outcomes. Is there a protocol for the home spirometry part of this study, or is it really that people are provided with a spirometer and told to use it as they would?
So as part of the pandemic provision, our National Health Service gave people a home spirometry device. It wasn't always the same device, so people had a device that was used by their clinical care teams, and if they had that device and if they were being recruited remotely, then our Data Safety Monitoring Committee was keen that there was more than one single measure of home spirometry at home, so that they wanted 3 different measures of spirometry over a 5-day period so that we could have more certainty in the robustness of the home spirometry measure in comparison to the clinic spirometry, but also that if the people were recruited remotely in the first instance, that their follow-up end-of-study visit would be with the same home spirometry device. Similarly, if people are recruited in the clinic, that they would have both their baseline and end-of-study result in the clinic spirometry, so that within person you would have consistency over the type of device.
Thank you very much.
Thank you.
And for our final talk, I'd like to invite Clement Rind. He is my co-PI on the HERO 2 study, and we are really excited to be able to share some of our preliminary thoughts.
Great. Well, thank you, Cindy and Greg, for inviting me. Thank you for all in the audience who didn't leave right after you heard about the Simplify results. Hopefully you'll find the results that I'm going to present of interest. I'm going to talk a bit about the design of HERO 2 and provide you with some preliminary information about the enrollment characteristics. Okay, right. I have to do that. Right. Okay. So these are my disclosures. So again, fortunately, all the previous speakers have provided a lot of the rationale for doing studies like HERO 2 and the other studies. The ETI is a highly effective modulator therapy for people with CF who have 1 or 2 copies of F508del, and the effectiveness of ETI in correcting the underlying defect in CF raises the possibility of reducing the need for chronic daily therapies. We've already seen the results of Simplify and CF Storm will also answer some longer-term questions, but there is also a role for real-world research to complement some of the data from these RCTs. So the objective of HERO 2 is to assess the impact of ETI therapy on changes in chronic CF treatment regimens in people with CF. And we have 2 specific aims. The first is really just understand the proportion and clinical features of people with CF taking ETI who make changes to their chronic daily therapies. And then the second is to assess the relationship between changes in chronic daily therapies in people with CF taking ETI and changes in pulmonary outcomes such as lung function and pulmonary exacerbations, as well as identify clinical features associated with stable pulmonary outcomes following these changes. This slide summarizes our study design. This is a prospective observational cohort study. Each person with CF will track symptoms and medication use for 12 months using the smartphone app, which I'll show you in a moment. And we actually have pretty broad inclusion criteria and very few exclusion criteria. Basically, when we were designing this study, actually, ETI approval for under 12 hadn't occurred, so we set our age inclusion criterion at 12 years. And then anybody about to start or currently taking ETI, as you may expect, most everybody is already taking it by the time they enrolled. And finally, access to the necessary technology, which could be a smartphone or could be a computer with internet. And our only exclusion criteria were being a recipient of a solid organ transplant, and because we did not have the ability to create non-English versions of our tracking questions, that they had to be able to, if they could not communicate in English, that was an exclusion criterion. So I think there's several innovative aspects of the HERO 2 study design that I'd like to highlight. The first is the use of a phone-based patient-reported outcome data collection system that allows daily collection of data, also has a fairly high end-user flexibility built in. The other thing is that we used, as I'll describe in a moment, in addition to standard recruitment strategies, we used a community-based recruitment strategy, which we had thought would help recruit underrepresented study populations and would augment traditional recruitment methods. And finally, similar to CF Storm, we use the CF patient registry to complement outcome data from our phone-based app called Folia. So as I mentioned, we used a couple of different recruitment strategies. Again, our primary one was the traditional center-based recruitment, but because all the consenting and enrollment took place in the app, we really were able to divide that into kind of two subgroups. We had what we called referral sites, who basically functioned similar to if you were just to tell people, give them a flyer which was IRB approved with a QR code, and just let patients sign up for the study. And then we had recruitment sites that we helped reimburse additional effort to more actively recruit patients to sign up. As I mentioned, we also complemented this with a secondary recruitment approach using community-based recruitment methods through social media and other CFF patient groups such as Community Voice. Finally, there were actually a small number of people with CF already using Folia to track their own personal data, and they were invited to participate in the study. So I wanted to mention a bit more about the enrollment and data collection. So because all of the consenting and all of the interactions took place either on the app or through a previously IRB approved protocol at individual CF centers for registry, this was considered a single site study by Advara, the central IRB that we used. And as I said, so all enrollment and consent is done through the Folia app. So there's really zero study visits, because there's all the data are collected through the registry, and all the PRO data are collected through the phone app. We collected data at study initiation, as well as daily and weekly symptom and medication use. We also had monthly surveys looking at the treatment plan changes, as well as using a couple of QOL scores like Promise 10 and CRIS. And finally, there was an end-of-study survey. You might actually wonder why this is called Hero 2. That's because we had a Hero 1 study that piloted a lot of the feasibility aspects of this study. And one of the things that we were able to do is be able to match the Folia data participants to their CFF registry data. This slide outlines the overall kind of schematic of the study design. So if we kind of just, the top line here is our timeline. Enrollment would start here. As I said, most patients were already on ETI, and so that happened sometime before enrollment. And what we used is the date of prescription of ETI in the registry to identify that time point. Knowing that sometimes people get it prescribed and don't start it right away, but we felt that was close enough. And again, using the registry, we're going to be able to obtain their baseline data and then follow them with their post-ETI data. And then down here on the bottom, that's complemented by data from our phone app, doing baseline survey, daily tracking, the monthly surveys that I told you about, and finally the end of study survey. So I've mentioned before, but just want to give a little bit more detail about Folia Health. So this is a commercially available phone-based app for patient-reported outcomes. As I mentioned, this can be accessed using either iPhone or Android, and it can also be accessed using a desktop computer with internet. Over here on the right are just some representative screenshots. They may not come up that closely, clearly, but basically, you have little radio buttons for the medications you're taking, sort of what you've done every day and how you're feeling. And there's really kind of two sets of questions. So we certainly had our study questions that we wanted patient participants to answer, but there is also the opportunity for people to track other things that we might not be tracking quite as closely. So this figure shows our enrollment. We started enrollment last June, and as you can see, a couple months ago in August, we reached our target enrollment of 860 participants. I'm actually going to show this as a pie chart, but you can see that we started out originally more with community enrollment, and it took a little while to get our referral sites and recruiting sites online, and so then nearing the end they were contributing more. This pie chart kind of gives you a better idea of sort of the distribution of how study participants were recruited. As you can see from this pale blue and darker blue wedges, you can see that the majority of patients still came through our traditional recruitment method. But about a fourth came through our community recruitment plan, and we had a small percentage, about 6%, that were existing Folia users. So what I'm going to do now is just share with you some of our preliminary look at our baseline characteristics. So this slide summarizes the demographics of the HERO2 participants, both the total as well as community, and we kind of lumped recruitment and referral together because there really wasn't a huge difference, and actually community includes pre-existing users because, again, that was a pretty small number. So I think there are some pretty striking and interesting observations. First of all, our mean age overall is in the late 20s, but again, the community recruited participants definitely were a little bit older. There was a strong female predominance in our participants, whether it was through community recruitment or referral route of recruitment. Primarily white race, and again, we didn't have a Spanish version, so only about 5% were Hispanic, and then the F508del variant status is consistent with what we would expect, except there's like 30 that had none, so we're actually still trying to figure out, because in theory they shouldn't be on ETI, but we're still figuring out those 30. This slide summarizes the history of CFTR modulator use. I'm not really going to go through this slide in great detail, just simply to say that obviously the majority of people had been on ETI for a while, and again, most of those people who were F508del homozygous had been on lumacaftor, ivacaftor, and then were switched to tezacaftor, ivacaftor when they were when it became available. I should have mentioned in the previous slide, you notice that our total N here is 787, not 860. That's in part because right now all of this is based on the 2020 registry data, so we don't have everybody, some people are not in there because of that. There are some problems with matching, so we didn't match every single patient yet, and there were actually some duplicate enrollees. So that's why that total number is a little bit smaller than 860. Here I'm just showing some of the salient clinical features of our HERO2 cohort. You can see that actually in terms of encounters in 2020, that was pretty similar across both of the recruitment methods, and it was about 2.5. So basically 2 to 3 times a year. There were slightly more Medicare insured patients in the community group, but again, I think to me, one of the things that stands out, and we'll see that with kind of the subsequent slides, is that the community recruited group tended to be a bit sicker. There was a higher percentage of CF-related diabetes as well as sinus disease. And when we look at their baseline pulmonary, nutritional, and microbiology status, we also see those similar trends. First of all, overall, I think this was a relatively healthy cohort. The FEV1% predicted mean was 80.6%, although that's actually less than the participants in Simplify. Again, you can see statistically significant difference between the community enrolled versus recruitment referral group, and again with the community enrolled group having even lower FEV1. If you look at the absolute BMI for older patients or BMI percentile, again, actually pretty good. And again, but a little bit lower in the community group. I think the BMI percentile is not statistically significant because, again, the numbers are kind of small. If we look again at things like microbiology history, higher rate of P. aeruginosa positive patients in the community group. This slide shows their reported baseline pulmonary therapies, and consistent with all the slides we've seen before, you can see that there's a relatively high treatment burden. The vast majority of patients were on bronchodilator, Dornase alpha, vest airway clearance method, hypertonic saline, as well as inhaled antibiotics. If you think about the number of inhaled medications every day that these patients were prescribed, it was really quite high. And finally, this slide shows the reported changes in therapy at study start. So you can see that, well, first of all, like 41% of participants reported stopping at least one chronic therapy. So just as been alluded to before, there's lots of people that have not been waiting for the Simplify results to make their decisions. And as you can see, it's kind of distributed, kind of amongst many things. 30% have discontinued their inhaled antibiotic, 30% have discontinued their airway clearance, and perhaps lower percentages have discontinued Dornase alpha and hypertonic saline. So to summarize on the results, I think we've shown that study recruitment through social media and PRO collection via smartphone apps are possible, are feasible. I think there's several notable aspects of the HERO2 enrollment characteristics. As I mentioned, this strong female predominance, a clear difference between the community recruited group versus the referral sites. Overall, the study cohort is healthier compared to the general CFF-PR population that may represent issues related to access to the technology. It may also represent that they're more engaged or more thinking about paying attention to their health. Consistent with other studies, there's a high burden of prescribed medication use, and many HERO2 participants have stopped at one or more chronic medication. I think the other point to make is that we had thought that we had kind of hoped that by being able to do this all remotely and using community recruitment, that we would have been able to broaden the participation, especially without having to have study visits, that more people would participate. But if you look at kind of that percentage, I didn't put the majority of the non-white people with CF are black, and that percentage is still lower than again the registry overall. So, and again, we didn't have the Spanish language option, so that probably affected us too. So, I think in the future that we might also have to think about different recruitment approaches to enroll a more diverse cohort of people with CF into research studies. So again, this is kind of really our preliminary data. Over the next steps, obviously we want to kind of analyze more carefully the enrollment characteristics, looking at recruitment method. We want to collect more data on tracking so we can see how frequently people are tracking. Probably do some more comparisons of the characteristics of the different recruitment cohorts. We have the registry data, so we can look to see because again, remember the CF Foundation, at least in the US CF Foundation registry, doesn't record what people are taking. It records what they've been prescribed. So we'll compare that to their self-reported medications. And then finally study, again, kind of getting back to our original aim, study the relationship between baseline clinical status and characteristics and self-reported chronic medication changes. And then hopefully a year from now, we'll have had completed our 12-month tracking data, and maybe we can present you with some outcome data as well. So I want to acknowledge the many people that have contributed to this, in particular my co-PI, Cindy Brown, Kevin Soder, our biostatistician. Really have to thank and acknowledge Kathy Sabadosa at the CF Foundation, who really helped drive this originally. Our partners at Folia, Nell Miansky-Liu and Connie Chang. Lisa Bendy is our lead research coordinator. Flora is our project manager. I also really want to acknowledge a couple of people who actually are no longer working with the foundation. Eliza Fink, many of you may know her. She used to be the director of epidemiology. She's now the director of research at the National Organization of Rare Diseases, but she was, again, really critical in the conceptualizing this study and designing it, and Lindo, our previous project manager. We again tried to work very closely with community members, and we had our project team partners, Gunnar Esiason and Jackie Schoberg, who are people with CF, and Laura Eddy, a parent of a child with CF, and finally all the people with CF and their families that are participating. So thank you for attending. I'm happy to take any questions. I might not have answers, though.
Clement, thanks again for this talk, and we're again looking forward to hearing more from the study in the future. One question that's come in, for those that did report discontinuation of a therapy, was there data also asked of them if it was a self-discontinuation or if it was a decision that was made with their care team?
I believe we do ask that. I'm not sure, actually. I'm not sure. I'm actually not sure. I told you, I might not have the answer. That's a really good question, though. We'll go explore that.
Did HERO2 collect data on user experience with and acceptance of the EPRO application itself?
Yeah, so that's part of the end of study survey, is sort of the user experience on using the phone-based PRO.
Did anybody report discontinuation of more than one medication? You reported on the percent that reported on one discontinuation.
Yes. I don't have the specific percentage, but yes, there are definitely people who have stopped more than one.
So when thinking about the lack of underrepresented recruitment, how do you think that if we're trying to reach minority populations, do you think lack of cell service or not having access to computer could have played a role in that? And is this something how could we overcome that?
Yeah, I definitely think we need to look at whether, not having access to technology, how that affects things and how we might be able to ameliorate that. Probably working with organizations like the National Organization of African Americans with CF for strategies as well. So.
And you mentioned about the baseline level of what they're doing for airway clearance, but are people being asked to record what type of airway clearance they're doing or not?
Yeah, for the purposes of the figure, I just collapsed that down to the vest, because basically 90% of people report using the vest, but we are recording, any other things like aerobica or a cappella and things like that.
And are you able to comment on or report at all about sort of the persistence of people using it? Sort of, do they use it for the first week or two after they sign up and then stop using it? Or are there patterns of use of the app? Is it variable?
Oh, yeah. So, no, we don't have those data yet, but obviously we will be looking. I don't think we haven't completed our analysis to be able to say for sure, to look at like how sustained the tracking is and the frequency of tracking over the 12 months.
I'll follow up on that. I think one of the high-level patterns we see is if a patient accepted it, started it. If you started it, you continued it for the most part, but there was some initial drop-off, and that's what we're trying to dig through, is to look at if you activated, you tended to stick with it, but there were a group
Yeah.
of people who never activated.
Yes, that is our preliminary impression, is that either people are, if they're going to do it, it's not like they're going to sign up and then start tracking like 3 months later. They either, but if they start tracking, they usually keep tracking. It's, and again, I think it may reflect the type of people who are signing up.
Well, thank you, and thank you to all for listening to 4 great presentations. I'm sure the speakers will be up here afterwards as well to answer any questions.